Good evening, everyone. We're just going to give everybody a few minutes to join. A warm welcome to wherever you are in the world. I know we've got people from all over tonight, so that's quite exciting. Okay, so for those of you, I know we have some newbies online tonight, so brilliant. Thank you for joining us. If you don't know about who we are the Eosinophilic Diseases charity. We are based in the UK, but we have a global reach. And we have two arms to our organisation, both patient carer support, and alongside it, we have a global healthcare professional network, which now reaches in fact, I've lost count because we've just come back from a conference. It was 48 before we left, but I know we've got some extra countries during that time, so it's definitely over 50 now. And our mission is to ensure that every person with an eosinophilic associated disease receives a prompt, accurate diagnosis, and most importantly, cohesive care and support to live with their condition. And all our work is centered around that. And tonight, I'm very excited to be delivering this topic, which is something that I know a bit about, not masses about. We've had personal experience with both of my children, so I've got an idea of what's going on. But this is definitely an evolving space, very much like eosinophilic diseases, let alone the crossover between when you have more than one of these conditions. And so very excited to be talking about this. And whilst we're here this evening, we're going to be introducing a couple of members of my team to you so that you know if you need any help. For those of you that haven't met me, don't know me, I am the chair and founder of EOS Network. My name is Amanda. And alongside me tonight, we have Alina, who is our communications officer. She'll be the person that's been sending you all those reminders. And if you have any technical difficulties, she'll be there to support you. And I'm also pleased to say that we have Karen on board with us tonight as well, sorry. And she's there in the background. Great to introduce her too. Okay, so to no further ado, I'm very excited to introduce you to Joshua B.Wechsler. Anybody who was on our call earlier last month, actually now time flies, he was with us talking about mast cell, and he's very graciously offered to come along and talk about connective tissue disorders and dysautonomia, which is an area of his interest, and looking at the overlap with gastrointestinal diseases. And he is an assistant professor at the Lowry Children's Hospital and Northwestern University Feinberg School of Medicine. And so this evening, just to give you a little bit of a highlight of what we're going to be covering, presentation will actually be slightly longer than that because we've included some extra bits that I think are going to be important to you. We're going to give an overview on both of the diseases, talk about the cause and prevalence, so how common it is, and then talk about the overlap with eosinophilic gastrointestinal diseases and how and when does this play a part in diagnosis and holistic care. And then we're going to do a Q&A, which I'm very excited to do, which will explain how that will work to you later on. And the leftover time, we're going to have an informal community chat, which will be very exciting. Okay, so let me stop sharing. It's enough from me. You've heard enough from me already. And if you would like to start sharing, wonderful, Josh.
Fantastic. Really appreciate the introduction and absolutely the opportunity to talk to you all about a topic that I became passionate about because I realized I was missing something with my patients and needed, as always, to understand what is it, what does it mean, what does it tell me about the disease process, or is it just unrelated, related, and then what can I do about it? And I'm going to tell you some background, as was described, as well as a research project that we've been working on and we're hopefully close to publishing in the next few months, because I think it will be ultimately one of the very first reports that really entrenches the idea that these conditions are clearly interrelated. And how they're interrelated, we're still trying to figure it out. And that's a little bit of the interesting part of the story that I'm going to tell you that maybe will come as a bit of a surprise. So these are my disclosures. I'm not going to talk about anything directly related to them. So eosinophilic esophagitis, as you all may be aware of, is a chronic inflammatory disease complicated by fibrostenosis. You can see pictures of the esophagus up here, inflammation, rings, exudate, and a normal biopsy in the lower left, and a very inflamed biopsy in the lower right. A schematic indicating the degree to which that inflammation progresses from, again, inflammation to scarring. So this is just sets the stage for what is EoE. How does it work? Well, you start with the intact tissue, the lining. This is the superficial tissue where I take a biopsy. Some food starts to pass by, gets picked up by these professional cells called presenting cells, or APCs. It tells these T cells to start making some things called cytokines. These are communicating molecules. Those T cells start to expand, produce more cytokines, call in those eosinophils, secrete more cytokines, things like interleukin 4, 13, 5 now playing a big role, change a bunch of molecules within the tissue that cause it to start spacing apart. That's where you get these things called dilated intracellular spaces or basal cell hyperplasia. Now, all of a sudden, those eosinophils and now some mast cells start marching in. You get this big inflammatory cascade. And downstream of that, there's a lot of changes, particularly related to the mast cell and the T cell, that are driving a lot of things like symptoms and scarring that ultimately become a part of today's talk. So not to remember every little less detail, but to realize this is a complex process involving this increase in the number of mast cells that ultimately get activated. That's definitely an element that I want you to keep in mind as we talk about this. Mast cells are increased in EoE, as I mentioned. This is just some data from 3 studies showing it, but there's half a dozen more. And we showed you, and I showed you last time, that we can detect mast cells in the esophagus using these activation markers. We see that there's higher numbers of them present at various times. And this is really, really, really valuable information because it tells us that there's chronic mast cell activation going on in the tissue. So this is just an element that we know EoE by which EoE exists. And indeed, if we just check your blood for your serum, we can see beta tryptase elevated in active EoE patients compared to controls in patients in remission. And it tells us that there might be leakage from the esophagus, or even there could be systemic mast cell activation. We're not really sure, of course. And mast cells have tons of functions, as I mentioned. They release a lot of different molecules, some that they have preformed called tryptase kinase. These are proteolytic enzymes or serine proteases. Other things like cytokines, interleukin 13, as well as things like TGF beta. And these have impacts on the muscle. These have impacts on fibroblasts, as I mentioned, or on the tissue, and importantly on nerves. And that's going to become a factor as we go through all of this. Well, like I said, mast cells interact with sensory nerves, and this may be important because it might be driving an element of the symptoms in EoE. Here's a study in which they took mast cell activation. They basically activated mast cells in a test tube, and they looked at how it changed evoked action potential. This is like nerve signaling. This is like how excited the nerve appears. And you can see the numbers between control and the mast cell activation group go up. And they were able to find a particular molecule replicate that, and that's a molecule that looks just like tryptase and works on the receptor for tryptase. So tryptase being a key enzyme that's released by mast cells, and this just showing what that signal looks like before they gave that molecule called PAR2. It's a PAR2 peptide, and then after, you can see that increase in that action potential. And also, and I showed you this before as well, there's this relationship between mast cell genes and neuron genes, and higher numbers of mast cells in patients with chest pain, and this close relationship of mast cells to neurons in the esophagus. So this is sort of sets the stage on some level for what may be going on. And I even presented you something like this, where we found that there's higher numbers of mast cells in patients that have nausea, vomiting, or pain. Again, suggesting mast cells might actually be playing a role in symptoms. They might be contributing to some symptoms that patients have. We really don't understand why necessarily. Well, don't forget that there's mast cells present throughout the entire GI tract. The whole GI tract has mast cells. Different studies that have looked at different amounts. You don't need to memorize which ones, but to remember at least that this is definitely something that is a factor in all of this, is that there's mast cells sitting everywhere where there's an interaction between the body and the environment. And as food travels through your GI tract, that's technically the environment. It's the outside world to your body. And also a key element of the GI tract is the enteric nervous system. So there's lots and lots and lots of nerves. People say it's the second most rich site of nerves after the brain, sitting in the lining of the GI tract that reaches very close to the surface. And mast cells potentially have the opportunity to interact with these neurons. This is a really cool 3D rendering where the mast cells have been labeled in green and the nerves via the receptor CGRP have been labeled in red. And actually, people use drugs against CGRP to treat migraines because it blocks neuron signaling. You can see there's this close relationship of the nerves to the mast cells. So there's this clear interrelatedness of how mast cells and neurons are communicating. And really, again, there might be this role for mast cells in potentially driving symptoms, and ultimately could be because they're just sitting next to nerves. And it would make a lot of sense, and it makes us wonder about other functions of the enteric nervous system. Now, separate from EoE, there's this condition called dyspepsia. Dyspepsia essentially is the presence of no pathology, but chronic abdominal pain, fullness, and nausea. Fullness being like you get full quickly when you eat, or other people call it early satiety. And this collection of symptoms, it's broadly referred to as dyspepsia. And people have looked at these mast cell neuron clusters from biopsies, and they found there's differences. So here they're comparing non-celiac gluten sensitivity, celiac disease, and functional dyspepsia. So here's the dyspepsia group in purple, and they see higher numbers of these mast cell neuron clusters compared to what they defined as healthy control. So there's this concept that maybe there's actually more mast cell neuron signaling going on in patients that have not just EoE, but also functional abnormalities now looking within the stomach here, not just in the esophagus. So they also looked at correlations between bloating severity, abdominal pain severity, and they found very interestingly that there did seem to be some correlations between these mast cell neuron clusters and the mast cell density with regards to these symptoms. So again, potentially not just a relationship in EoE, but even a broader relationship with regards to symptoms. So a bit about dysautonomia and POTS, because this gets kind of confusing. So dysautonomia, it's a very broad concept. It refers to dysfunction of the autonomic nervous system. And the autonomic nervous system regulates involuntary bodily functions such as heart rate, blood pressure, or digestion, and that's the enteric nervous system, and temperature control. So things that you don't have control over, your heart rate, your blood pressure, how your motility works in your GI tract, or whether you have a fever, things like that. That's all your autonomic nervous system. POTS is a specific form of dysautonomia, and it's characterized by an abnormal increased heart rate that occurs after sitting up or standing. Typically, it's a heart rate increase above 40 beats per minute, although that's probably the most technical definition. And there's a lot of subclinical POTS where they might have like 30 or 35 increase, and probably end up treating it very much the same way. And it's most common in females aged 15 to 50. So that's the typical age that you would find if you were looking at studies. Signs and symptoms include things like rapid heartbeat, lightheadedness, fainting, fatigue, brain fog, difficulty concentrating, nausea, shakiness, sweating, blood pressure, exercise intolerance. So a broad set of symptoms that are frankly common to a lot of people. And, is it dysautonomia? Is it POTS? And this gets really confusing because it's also it's also very linked to this thing called deconditioning, that you're very, very active and all of a sudden you're very not active. And then you will start to experience a lot of these symptoms. You may have transient dysautonomia, but it's hypertreatable in the sense that it's something that you could just start to get back to moving a lot more and have a lot of success with that. And I'm seeing some comments in the chat, and I'll certainly try to address them towards the end. Now, diagnosis and treatment of dysautonomia and POTS. So we're going to do a workup. Obviously, we're going to get a good history. We're going to make sure that we think that there's symptoms present, particularly the symptom of postural dizziness. That one is a very big one. But we might even be thinking about symptoms like chronic nausea again. A tilt table can be very helpful to confirm it. Although, again, if you don't meet the criteria, you have only 32 beats per minute increase with the tilt table, we're still probably going to pursue it. Urine-specific gravity can be helpful again, might show that you are kind of low in salt essentially. And we can check urine electrolytes as well. And then that's going to allow us to make some recommendations around lifestyle changes like increased fluids, increased salt. Particularly cardio is very helpful, or strength training, which I left off the slide. So leg exercises to increase the leg muscles. Whether there's a specific type of cardio that's beneficial, I think there is, like zone 2 cardio. This is zone 2 where you're able to have like full conversations as you're exercising, but still a lot more to be done to really prove something like that. Sleep, compression stockings are very helpful as well, and potentially drugs like fludrocortisone or beta blockers for highly refractory cases. Now, one thing we have observed is that POTS is increased in adults, and this is literally the only thing that exists around this topic. So in this particular study by Evan Dellen's group at UNC, he identified about 7 patients. I can't remember exactly the number of patients. I don't think it actually says it here. I think it might be on the next image. Yeah, he identified, I think it's around 7 or 8 patients. 7 patients, that's right, there they are. 5 of whom were female, 4 of them who had EoE, although some of them had other conditions. They all had POTS, but some of them had other problems, Ehlers-Danlos, mast cell activation. We'll talk a little bit more about that. And he characterized the symptoms. So you can see all these different symptoms like brain fog and syncope and lightheadedness and how some of them addressed it. And it was all sorts of different ways. And so he estimated based on this population that it was 1.25% of his population based on how he did a retrospective chart review. And that was increased relative to the general population, of which there's very poor reporting on this as well. Which is somewhere maybe around 0.2%, but we really don't honestly know. Now, how can we measure this in a way where we don't necessarily have to do tilt table tests because it's obviously very intensive? So Wolfgang Singer, who is up at Mayo, where there's a lot of Mayo in Minnesota, where there's a lot of expertise around POTS and dysautonomia in general, developed this survey called Compass 31. This was intended to be a short 31-question survey to characterize the different elements that the different systems or different symptoms involved in POTS, things like orthostatic intolerance, that's the dizziness element, the vasomotor element. So this is essentially going to equate to like, seeing changes on your skin, things like that. Secretomotor, whether or not there's feeling like dryness, things like that. GI symptoms, bladder symptoms, so whether you're having like urinary retention or pupilomotor, so things related to your eyes. And he looked at a POTS population, a population with autonomic failure, as well as some healthy controls, and he saw some very clear differences between the POTS and control populations, just as he saw with the autonomic neuropathy patients, but he didn't see those differences when he was comparing POTS versus autonomic neuropathy, because of course there's a lot of overlap as we would expect with a good survey, that's encompassing these conditions. So unfortunately, the survey can't really differentiate between autonomic failure or POTS, but undoubtedly with autonomic failure, it's a much broader condition, and our patients are going to be much sicker, and we're not really generally going to be seeing those patients in an outpatient setting. Now, we've been very curious about this for a while, and with COVID, you may remember there was this whole big thing about long COVID, and long COVID being potentially POTS being a big element of it, particularly in adults. And so we've been very, very, very curious about what might be going on in children, and we did this survey, and the only way I could figure out how, which was all survey based, all remote. Basically, patients that we had a list of patients that had gotten COVID tests. And sent them a slew of surveys to understand, were you sick before your COVID test? And then how did you feel after your COVID test? And I've gone back and reanalyzed the data now just for you all today to really focus on the patients that completed the Compass 31 survey, because they completed a whole slew of surveys. But the Compass 31 was a particular survey because we really wanted to understand, is there POTS following COVID in children, which again, unknown at the time. So you can see here our control population. They had no symptoms, and it looks like I left off the one in cough, and I apologize for that. They had no symptoms prior to their COVID test. There's the non-COVID infected patients. These patients were symptomatic but had a negative COVID test. And then there were the COVID patients, and we had a small number of these, but they had COVID obviously positive on their test. And you can see there were some subtle differences in the symptoms between the COVID patients and the non-COVID infected patients. And this really speaks to, the uniqueness of COVID, I guess, as an infection. And we looked at whether there were any differences in Compass 31. We really saw nothing. We when we looked at the trends using Z-scoring, we could see that there are some subtle differences, at least, in terms of different elements of the Compass 31 survey. So more vasomotor, more pupilomotor, it seemed, symptoms, but nothing that really stood out as being clearly significant. What we did that was super interesting also is that we looked at whether there was a correlation between this Compass 31 survey as well as other GI symptoms that we had assessed, as well as this survey that was developed at Lurie called the Nausea Profile, and it looks at emotional symptoms and somatic symptoms. And so emotional, I think probably you're all very much aware of, as well as somatic symptoms relates very much to, am I queasy feeling? Do I feel uneasy? Those kinds of symptoms. And it's more like systemic in your whole body. This is supposed to be a manifestation of nausea in the rest of the body as opposed to a more focused GI symptom. And you can see this incredible relationship, right? There's a very nice relationship between the Compass 31, which is measuring dysautonomia, as well as just straight up GI symptoms, dysphagia, reflux. And again, this is not an EoE population. This is a population that showed up for a COVID test. So it's sort of a real world population of patients. And we can see that, there is clearly a relationship to GI symptoms you have, emotional symptoms you have, body symptoms you have, and this measure we now have of dysautonomia. Okay, going to take a break for a second on the dysautonomia front. We're going to talk about connective tissue disease for a second and hypermobility. So what is CTD? So connective tissue disease or connective tissue disorders involve proteins that support skin, bones, or blood vessels. So anytime, or you can even say like tendons, that kind of thing. So anytime you have something holding something together, essentially, there's supporting proteins. Big one you might be familiar with is like collagen, for instance, and there's laxity in these proteins. And then as a result, there's laxity in these organs or tissues. And this, of course, is going to create symptoms. And there's large number of subtypes of things that involve connective tissue. And this could be autoimmune, vascular, and the most important one related to what we're talking about is hypermobility. Now, hypermobility itself is a spectrum too, and it's a spectrum by which joints move beyond what's considered their normal range of motion. And this can be to the extreme level, involving many joints throughout the body, as well as other organ systems. That would be classically defined as Ehlers-Danlos syndrome. It has very strict criteria now that was revised several years ago, as well as what's much more common, which is hypermobile spectrum disorder, where there tends to be more isolated hypermobility, but it goes beyond the level of, again, what's considered normal. So signs and symptoms here involve joint hypermobility, a history of joint pain, joint dislocations, soft, stretchy, or fragile skin, easy bruising, fatigue, gastrointestinal symptoms. They can be like IBS-like, constipation, or even sometimes loose stools. They can have cardiovascular manifestations. We'll talk about that in a second. And an important factor is oftentimes delayed wound healing. So CTDs are, there's an increased risk of them in EoE. And you can see from this particular study here where they classified CTDs throughout the chart. You can see the list of codes, including things like Marfan, Ehlers-Danlos, Loeys-Dietz syndrome, that when they looked at the percentage in EoE patients, it was 1.3. And when they looked at the percentage of CTDs in patients with EoE, it was 0.8. And then as they went through and looked at the EGIDs, it was 3.3 now. So again, an increased number of EGIDs and increased numbers of EGIDs in the CTD patients. And when they looked at the CTDs, then they saw that same increase. They said maybe 11-fold higher. Now, how do we address this? Well, in clinic, we'll do a workup that involves a Beighton test, and we'll talk a little bit about that later on, but this is a test of specific joints. We'll oftentimes do genetic follow-up or maybe rheumatology follow-up for more thorough testing, because in GI clinic, I don't have time to oftentimes go through a very deep workup that for other manifestations involving, like, let's say, skin or neurological, and again, taking more of a bullet point history and focused largely on EoE, obviously. So we have clinics that are really, and experts that are really more focused on the hypermobility component, and we'll do a broader workup. Potentially, if they see evidence of a vascular element or something like Marfan's or low EGIDs, we might be doing a genetic workup. Rheumatology eval if there's swollen joints, and dermatology evaluation if there's RAS, and there could even be labs involved, and echo certainly to work up the heart. Treatment is really pretty limited, actually, because to the extent that you find something, if it's an inflammatory disease, an autoimmune, you certainly might treat that. But for hypermobility alone, there's really not an actual treatment. So you oftentimes are best just maintaining a very steady, active lifestyle and very much aggressive PT. Those are really your two main things. Sometimes occupational therapy can be helpful, but there is literally otherwise no actual treatment beyond that. So, I do, and I will say, I do find patients that actually don't have an active lifestyle, but are very hypermobile. And when I think what's notable about them is they're just completely sedentary. So they never were active. I would say for my teens, a lot of them are love playing video games, and they're listening to music. That's the lifestyle they have, and they really don't have a lot of symptoms, but they just happen to be hypermobile. And unfortunately, the degree to which you're hypermobile doesn't always predict whether you're going to have joint symptoms or not, which of course is what we're looking for when we're screening for hypermobility. But definitely an important thing to think about, because again, that broader workup, especially that echo, we think is very important. We certainly wouldn't want to miss a cardiac manifestation early in life. And indeed, there's increased GI symptoms in hypermobile patients too. So you can see from this study a wide variety, things like abdominal pain, nausea, constipation, diarrhea, heartburn, pelvic floor dysfunction, IBS, and a whole bunch of upper tract symptoms as well, belching, dysphagia, vomiting, all sorts of things going on in these patients. This is just they then also quantified it based on POTS positive and POTS negative in this particular study. And again, you can see all sorts of increased symptoms among these patients. So seems very common to find a patient that has POTS or hypermobility, and they're going to have all sorts of GI symptoms. That's really the message here. And indeed, when they looked at hypermobile patients, they have increased Compass 31 scores compared to the hypermobile spectrum disorder. So again, the most severe version of hypermobility compared to a more mild or moderate version of hypermobility, which is HSD. And now you're seeing all these increases in the scoring for the hypermobile EDS patients. So again, it speaks to the fact that the most extreme version is certainly causing an increase in these overall symptoms. And here, some data from our center that's really hot off the press. We actually have a retrospective study where we're looking at patients that underwent endoscopy for a very specific test, and across 99 of the patients, we're able to classify them as either having dysautonomia or POTS or not, or orthostatic intolerance. And you can see that the profile of these patients was very distinct. These patients were predominantly female. They had lots of nausea, abdominal pain, early satiety, bloating, chronic pain, anxiety, depression, and they were very, very commonly had hypermobility or Ehlers-Danlos syndrome. So there's definitely a very specific profile that is very distinct to Ehlers-Danlos, to hypermobility, to dysautonomia, and to this collection of GI symptoms. And of course, there's this triad that's been created that involves MCAS, or mast cell activation syndrome. And it's just a study looking at the frequency of MCAS syndrome retrospectively as it pertained to things like hypermobile spectrum disorder or EDS. And you can see 20% of the patients in this particular study had evidence of mast cell activation disease. They used the D instead of the S, as well as the hypermobility. And there's this triad that's now thought of as I was mentioning. And again, here in this particular retrospective study, 195 patients, 8% of them seem to have all three: POTS, EDS, as well as the mast cell activation syndrome. So there seems to be a direct interaction of the problems that POTS experience. Of course, many symptoms overlapping with the symptoms that EDS patients experience. And we talked a little bit last time about MCAS, and really it is very very complex condition, of course, because not every patient's going to have the sort of classical versions with the anaphylactic-like symptoms, and the complexity to which that all sort of may interact is really unknown. What is actually occurring in the context of a condition like EoE, where all of this seems to be happening. As I mentioned to you, there's mast cell activation known to occur in EoE. I've shown you some evidence of hypermobility and dysautonomia, and I'm about to show you a lot more. And so we think maybe that represents a subtype. And we're going to talk about, to what extent it is a subtype and maybe to what extent it isn't a subtype. And that's, I think, where this all gets very, very interesting. And we hypothesized as we went through this work that EoE patients have a high degree of dysautonomia that is associated with hypermobility, upper GI tract symptoms, and increased gastric and duodenal mast cells. So we have been prospectively enrolling patients undergoing endoscopy for suspected or diagnosed EoE. We collect demographics, medical history, as well as the Compass 31 survey, a connective tissue disorder survey, as well as symptoms of EoE, which is this PEAS 2.0, and a quality of life survey. So you can see that we enrolled 126 patients. Some of the patients did not complete the Compass 31, some didn't have EoE, one of them had eosinophilic gastritis, and so we focused on 80 patients for our analysis here. This is the patient population. You can see that about a little over half of them have active disease, active EoE, that there's a smattering of atopy, the allergic diseases like asthma, eczema, allergic rhinitis. These patients have an average age of 11, and mostly are male, as is common in EoE, of course. And you can see that just the measure of inflammation, it's pretty significant. So among the patients that have active disease, there's a lot of inflammation present, is what that tells us. Well, we initially looked at the relationship of the Compass 31, again, the measure of dysautonomia to demographic features, because we want to understand if there's the relationship to age or gender or BMI or something like that. We're gonna have to control for that as we move throughout. And you can see that on the left here, there's a relationship between age and the Compass 31, that there's a significant p-value of 0.04. It's not a major relationship, but it's enough that it gives us pause to think that it's possible as you get older, there might be some impact on the scores, and how much that interacts with the disease, we don't really understand. No differences between males and females, and a non-significant trend with regards to BMI. And of course, to some extent, that might relate to age as well, because our younger patients tend to be the ones that are not growing as well. Okay, well, now on to this really, really exciting data. And you'll remember that previously I showed you that study that we had done on COVID tested patients that involved a control population. So again, those patients prior to the COVID test were asymptomatic. They did not report any symptoms for a 2-week period prior to the COVID test. And then following the COVID test, they had now completed these Compass 31 surveys. So this represented a real world population, essentially. So some of them are probably going to have symptoms of dysautonomia because it's not necessarily a perfect healthy control population. And we didn't really gauge the extent to which you might have an autoimmune disease or things like that. And so again, more of a real world population than a true control population. But what we find is a significant increase in Compass 31 scores in our EoE population. And importantly, we see that there's a significant increase in the orthostatic measure. This is the measure that's going to give you the dizziness, as well as the GI symptom measure. That's not surprising. We know that EoE patients are probably going to have more GI symptoms than a random control population. So really, this reflects probably for the very first time, very clear evidence that there's increased orthostatic symptoms in EoE patients compared to a real world population. Now, we also broke the EoE patients into active disease versus remission, and we saw a significant increase in the Compass 31 scores there as well. So it appears that when you're presenting with active disease, it's not uncommon that you'll actually have more dysautonomia symptoms. And you can see, although none were statistically significant because it's not powered for that, you can see that there was a trend towards an increase in a variety of symptoms, including the orthostatic, the gastrointestinal, as well as the pupilomotor symptoms. And I think that's super interesting, of course, to think about the fact that multiple systems may be involved in that process. Now, we, of course, wanted to understand, is there a relationship between the Compass 31, the measure of dysautonomia, as well as other symptoms the patients may be having? And we had 2 ways of measuring symptoms. One was through a QOL survey that has a symptom component. And two, again, is through the PEAS survey, which has a variety of domains. And you can see, again, a really nice weak to moderate correlation between a variety of symptoms. Particularly, you can see the GERD symptoms and the pain symptoms. Again, go back to that idea that many patients with higher numbers of mast cells were having pain, and the Compass 31. So it wasn't the classic symptom of EoE, which is dysphagia. In fact, you can see dysphagia has almost no relationship to Compass 31, and it's maybe the other symptoms, the things that like we really have a hard time explaining, like why is my patient having nausea? Why are they having pain? And maybe it's because there's actually some autonomic nervous system dysfunction. I think that's really what this might actually imply. Now, I don't want you to get too bogged down on this, but we broke down each of the components, and you can see that many of the components, orthostatic, vasomotor, and on and on and on, have a nice correlation between a variety of the symptoms, mostly, again, focused on that GERD, on that nausea and the pain domains. And so a significant relationship between a number of symptoms, undoubtedly, and a number of things that aren't measuring GI symptoms. So when we talk about orthostatic, vasomotor, secretomotor, pupilomotor, those are not GI symptoms. Those are actually autonomic symptoms. And so when we're seeing those relationships, it's making us wonder, well, maybe actually some of these symptoms aren't driven by sort of the classical understanding that there's inflammation driving esophageal organ dysfunction. There's actually something else going on that might be driving those symptoms. We also saw a nice inverse relationship between quality of life, and the Compass 31, and here as the quality of life is probably something where the lower scores on the Compass 31 and the higher scores on the Compass 31 and the lower scores on the quality of life indicate that there's poor quality of life, as there's more dysautonomia present. And so that relationship, obviously not terribly surprising. It makes perfect sense. I think that a patient that's struggling with dysautonomia is probably going to have a very poor quality of life overall. Now, of course, you're absolutely wondering, I'm sure at this point, is there an intersection between the dysautonomia and the hypermobility? I think this is a really important question. I'm about to show you some really interesting data around that. So we use this validated survey that's been published since 2017, that assesses 5 symptoms, and based on the answers that you provide to these questions, you can sort of say that the person is generally speaking hypermobile or not. But to make sure that this was probably a good measure, we did Beighton scores on a number of the patients. And you can see how the Beighton works here. It's measuring things like the pinky, the thumb, the elbows, the knees, and whether you can bend over and touch the ground. All things that I can't do. But if you can do them, you might be somewhat hypermobile. And you can see that when patients had a higher hypermobility survey score, they had a higher Beighton score. That's great. That's what we're hoping for. So I think both these measures are great measures, potentially at assessing different elements to which hypermobility may exist. And of course, our surveys are imperfect. We might not assess all the correct joints, and so not surprising to see some patients where it doesn't line up perfectly. Well, here's our population of hypermobile and non-hypermobile patients based on who we recruited, and we saw no differences other than age. So we saw that the hypermobile patients were a little bit older, but really otherwise there's no differences between them. And that's probably reassuring, like that this is not a problem that necessarily is influencing other elements of the process, more of an association than anything else. But interestingly, when we broke the patients into hypermobile and not hypermobile, we saw markedly increased Compass 31 scores. So you're hypermobile, you're more likely essentially to have a higher degree of dysautonomia present. And indeed, when we looked at just the hypermobility score alone, so this excludes now the Beighton score, we see a nice correlation there as well. So depending on how we define it, sure, there might be slight differences in that relationship, more significant, a little bit less significant. But at the end of the day, I think what this really emphasizes otherwise is that when you're hypermobile, much more likely to have increased degree of dysautonomia. And we looked, of course, at what are those elements, and we saw that both the orthostatic and the vasomotor domains were the domains that were significantly increased in the hypermobile patients. So again, our hypermobile patients are having more of that dizziness. They might also be having more of that vasomotor instability as well. So this is where they might be reporting that there's like a rash that they can't really explain or something like that. And I think to the extent that this ultimately seems to be my matching with my own experience in the clinic. I think it's really validating for me as a physician to understand the extent to which this is otherwise true. Well, we just wanted to prove to ourselves that undoubtedly it is indeed the hypermobility and the degree to which there's active EoE that's ultimately predicting this dysautonomia. So we did models. We just wanted to control for age. And the way these models work is if you see a significant p-value, what you're ultimately able to interpret is that factor has an independent association with the condition, with whatever you're testing it against. So whether we looked at whether you're hypermobile or not, again, based on the score and the Beighton combined, or whether we just use the hypermobility score alone from that survey, we see a nice independent association with the Compass 31, again, the measure of dysautonomia. We also see that disease status has an independent association as well. So having active EoE is essentially a risk factor for having dysautonomia, is what that tells us. Well, I'm not going to stop there because I know you're all waiting on this big question. What's the role of the mast cell? Because, geez, I've been waiting for years to get this answer myself because I hear everybody telling me, is it my mast cells that are causing my POTS and making me hypermobile? And, of course, this is a very imperfect study. I will say that to start, but it certainly highlights some very important things that we can think about going forward. So unfortunately, we didn't see a difference. So at least when we looked at active disease and remission, so no differences here. Maybe the patients with remission had slightly higher duodenal mast cells. And then as I was alluding to, we saw absolutely no relationship between gastric and duodenal mast cells as well as these dysautonomia scores. So on the left here, you'll see the different categories as well as the composite score. And then what we're looking at is a correlation. And when it's more redder, and then it will have a box on it, that would be a significant relationship. So again, no significant relationship between any of the measures from the Compass 31, as well as duodenal and stomach mast cell levels, mast cell numbers. So this doesn't tell us about activation. This doesn't tell us if there's more mast cells touching neurons. This just tells us that staining for mast cells in your stomach and your small intestine is not going to answer a question about why you're feeling dizzy. That's really essentially what this is telling us. And similarly, we looked at whether there's relationship between duodenal and stomach mast cells and other EoE symptoms and quality of life, and we didn't see a relationship there. And of course, we didn't stop there. We wanted to make sure this wasn't linked to hypermobility either, or was it? And we didn't see that relationship. And even when we broke it down by active EoE and remission, because again, remember there were some differences, at least with the Compass 31, we didn't see any differences there. So I think what this tells me overall is that staining for a mast cell on a stomach or duodenal biopsy is probably not likely to yield insight as to whether there's an explanation for why I have dizziness, chronic nausea in the context of EoE. And that doesn't mean don't do it per se. It just means it's going to be very hard to interpret that there's not a clear definable relationship where I know if there's high mast cells, if there's low mast cells, what does that mean as far as treatment and what to pursue. But I'm not going to leave you hanging. I wanted to make sure that you got some information about what actually could be going on, because we happen to be conducting this other study, as I mentioned, about patients that have undergone a very specialized procedure in their stomach called pyloric endoflip. And in pyloric endoflip, we put a balloon catheter into the pylorus. The pylorus is the sphincter at the end of the stomach, and we see how tight it is. And then we can measure that via this thing called pyloric distensibility index. And so the higher the number, the less tight, the lower the number, the more tight. And it turns out that the patients with dysautonomia actually have a less tight sphincter. The sphincter is more lax. It relaxes way easier. And that we can use that number, that pyloric distensibility number, and actually predict who has dysautonomia. And interestingly, again, we're still trying to understand what this all means. Patients that have pylorospasm, there seems to be longer degrees of spasm present. This is using a different test. This is using a test called manometry in patients that have dysautonomia. So potentially you could sort of imagine it like this. In the patients that have dysautonomia, their sphincters are generally more lax, but maybe when they encounter something that they don't want, they actually can spasm more. And this potentially is actually evidence that there's a problem with the enteric nervous system again, right? So it may not be that there's just higher mast cells, so just go stain for the mast cells because, you know, if I have more of them, that's the problem. I don't think so. I think what this actually tells us is that there may be a role for nerve stimulation going on that's contributing to some of the symptoms that we're seeing in these POTS dysautonomia patients. And ultimately, if we have better measures of mast cell activation or the interaction of a mast cell with a neuron, we might have a better way of understanding this. It's actually something my lab's currently engaged in through collaboration with one of my colleagues, Peter Osgood. So in summary, what I've shared with you is that children with EoE have increased COMPASS 31 scores, a measure of dysautonomia compared to a control population. Active EoE patients also have increased COMPASS 31 scores compared to inactive EoE. COMPASS 31 scores correlate with EoE symptoms and quality of life scores. COMPASS 31 scores are increased in hypermobile pediatric EoE, and hypermobility and EoE disease activity predict COMPASS 31 scores independent of age. And lastly, I shared with you some hot off the press information that dysautonomia appears to be associated with altered pyloric function. So my conclusion from this so far at this point is that hypermobility and dysautonomia represent significant comorbidities in EoE, yet they clearly have an unknown cause. And this really just speaks to the need for more research. Definitely funding this kind of research is really valuable. It's always been a struggle, I think, to get this kind of research funded because it's so hard to define patient populations and really do really valuable tests. And we're just very lucky at Lurie that we have a nice cross collaboration between my lab as well as our motility folks, where they happen to see a lot of patients that have a lot of GI symptoms and then end up having a lot of issues around hypermobility and dysautonomia, as I shared. So definitely want to thank those involved in this work. My colleagues in the EGID clinic, Dr. Hoffman, Dr. Werschel, my research coordinators, Kitty Keeley, Robert Peraza, as well as Zainab Dagani here, Brad Tinkle, who's a hypermobility expert, really helped me with laying out how we're going to do this study. Wolfgang Singer, I mentioned, was the guy who developed, the doctor who developed the COMPASS 31 survey, as well as my colleagues in the motility clinic, John Fortunato and Peter Osgood, Judy Marshall, who is a genetics APN and helped really turn me on to understanding this comorbidity. Ritam Patel, who's actually my medical student that I work with, has really done quite a bit of the analysis, as well as three key funding sources, Dysautonomia International, Cured, as well as the hospital itself. And with that, I'm absolutely willing to take more questions from you all. Just a nice little picture of the hospital here, as well as you can see where a separate building where my lab sits in the background, and then the wonderful team that I'm so blessed to work with. And with that, I will open up the floor. It looks like there's already lots of questions, and I am delighted to answer as many as I can.
Thank you so much, Josh. As always, you are a mind of information and amazing research. And I think from that last couple of slides, I think the thing we have to take away from these diseases is it takes a village, without a doubt, to help these patients have a better outcome. I think that is the biggest takeaway we can give to anybody, and it's most definitely one of the biggest parts of our mission now, is to try away, as we said right at the beginning, is cohesive care.